He- Hello, everyone who's signing in. Just to let you know that we'll start at 2:05, so we're just waiting for a couple more minutes. Good afternoon, everyone. So I'm going to get us started. We have a we have a short clock with these events, so I won't waste any time and get right to it. So thank you all for joining us. It's a strange snowy day, and I'm glad to be able to be here with you. So I welcome you all to the sixth iteration of our History of Now seminar series, which we're running jointly with History and Science and Technology and the Science and Technology program at SES. So over the past few weeks, we've had some really fascinating discussions on the history of race, cities, immigration, contagion, and demography. Today, we'll turn to a more anthropological approach, citing some of these historical questions in the contemporary. And I couldn't think of two better colleagues to do this with than Amy Moran-Thomas and Carlo. So keeping the bio is really, really brief, so we have more time to talk. Carlo is a reader in global health and social medicine and the social medicine program at King's College London. When the pandemic first broke out, the first book I turned to was his called The Pandemic Perhaps, Dramatic Events in Public Culture. This came out in 2015 and was a fascinating exploration of the 2005 flu epidemic that never really occurred. The perhaps in the title is a sort of giveaway there. And it'd be fascinating to see how that history plays out in the present, where this one certainly seems to have occurred. Amy Moran-Thomas is an associate professor of anthropology here at our own department at MIT. Her recent book, Traveling with Sugar, Chronicles of a Global Epidemic, considers the bodily legacies left behind by plantation landscapes in what many researchers are now calling planetary health. Um, just to point you to something Amy wrote recently, a recent Boston Review piece on uh, titled How a Popular Biomedical Device Encodes Racial Bias is just become essential reading for anyone thinking through today's issues, particularly in relation to race, and I'm sure it'll come up in our discussion today. So with that, let me turn us over to Amy or Carlo, whichever of you want to go first. Carlo?
Yeah, sure. I don't mind. Well, thanks so much, Vai, for this invitation. It's a great pleasure to participate in this series. So I'm very much looking forward to the discussion. As you mentioned, the book that I published in 2015 is called The Pandemic Perhaps. And I think now almost, back then it was the pandemic, there was a perhaps, and now almost everything has become a perhaps in our lives. So there's definitely been a kind of expansion of the perhaps in our lives. Now I wanted to start this brief introduction with just a few comments on preparedness. And I have prepared a few slides, so I'm going to share the screen now. Let's see. All right. So this is what I wanted to show you. This is, so, you know, preparedness has a very long history. It goes back to the Cold War, but then became very important after the terror attacks of 9/11 and the anthrax attacks. And since then, preparedness, the idea of preparedness has been at the center of a lot of projects, especially in the United States. So, but this, what I wanted to show you here is a report that was published in 2019, and it's called the Global Health Security Index. And it was published by a group of experts based at the Johns Hopkins University. And it was an assessment of preparedness across the world. It was also funded by the Bill and Melinda Gates Foundation and others. So it was a project team that worked with 21 experts across 13 countries. And they developed a framework with 140 questions in order to understand and measure preparedness. They used 34 indicators and 85 sub-indicators to assess a country's capability to prevent and mitigate pandemics. They looked at a whole range of different issues. They looked at first prevention, then they looked at detection and reporting, then they looked at rapid response, then they looked at the health system, then compliance with international norms, and even the risk environment was taken into account. So at the end of the report, when the data was analyzed, they came up with a ranking of preparedness. So they ranked 250 states in terms of how prepared they were. And this is the overall score, which is quite interesting because, as you can see, according to this report and according to this group of experts, the most prepared countries for a pandemic and for a catastrophic event was first the United States and then second the United Kingdom. Now, obviously, when you compare this with what you're observing today, then you would probably think that this score, this ranking needs to be revised. So this raises a number of questions. It raises a questions around expertise. Is this a failure of expertise? Or is it a failure of preparedness itself? But it also raises the question, what is preparedness as such? And I think what I have been trying to do in my work is to say that preparedness has taken very different shapes in different places. And it's important to understand preparedness within national security cultures, because preparedness means different things in different places. So what I would suggest in terms of preparedness in the United States is threefold. And it starts with a quote from Joseph Masco. Masco, in his book, said something very interesting. He said, the United States is a nation that increasingly produces the conditions of its own instability, politically, economically, environmentally, and then mobilizes the resulting vulnerability of citizens and systems to demand an even greater investment in security infrastructures. So this is my first point in terms of preparedness in the United States. Preparedness is a constant production of instability that is then used to justify security interventions. So there's a kind of mutual production of both instability and security. So this is the first point that I think is important to understand when we're talking about preparedness in the United States. The second point is that Preparedness means that institutions for social welfare are being downsized and partially replaced with security infrastructures. So I think this is the second important point to understand. And the third point is that security very often means that citizens are made responsible for their own survival. And you see this when you look at preparedness plans and exercises and projects, that very often the basic idea behind preparedness is that citizens themselves need to be mobilized, they need to prepare, they are responsible for their own survival. So I think I will just stop here with these 3 points about preparedness, and I'm looking forward to the discussion.
Thanks, Carlo. Amy?
Yeah, great. Yeah, I'm so glad to be here with you all and to think in conversation with the points that Carlo just raised for us. And maybe in a way, what I wanted to add to the conversation here, is sort of an object lesson dimension of, some of those logics. So I teach on the social lives of medical objects here at MIT, and I thought I'd tell you about 2 object sets I've been returning to lately, in my thinking about epidemics. So the first one comes from the case study I know best of diabetes, and the second is more directly involved in COVID. But I think both of them, for me, have become figures of thought for how I try to kind of approach some of these questions in anthropology, sort of trying to capture some of the social histories and human stories through objects is a way to think about how, so many of the big terms in anthropology about settler colonialism or racial capitalism or systemic inequities of all kinds. I think thinking about these big structures in relation to, the material pieces of infrastructure where those, things that can sound like metaphors are actually made concrete, and I think of as more synecdoches of these bigger structures. Okay. So a kind of overarching question that ties both these sort of object examples together is the question, how do we think about profit engines that connect history and present, which I think is very related to the question Carlo just left us with. Okay. So I'll also share an image here. Okay. So the first object I wanted to talk about, are you able to see that okay?
Maybe just do that again. I needed to make you a co-host.
Oh, sorry about that.
Carlo, are you able to see this?
Okay. Are you able to see that now? I can just describe the images if they're not showing up for whatever reason. I'll try one more time.
Yeah, just try one more time because you weren't a co-host before. Now you are.
All right. Are you able to see that now? Okay, great.
Great.
All right. So so these are 2 images of what people who I knew when I was talking to patients managing diabetes, both referred to as sugar machines. So sugar machine was the name some people that I met used to name their glucometer, which was supposed to help measure and manage blood sugar. But where I worked in the Central American country of Belize along the Caribbean coast, but like in many parts of the world, the devices were sort of always breaking down in these really predictable ways, and people's bodies were kind of breaking down in relation to them. But I was so struck that people use the same term for these machines breaking down in their houses, which were sort of meant to, allow them to live with blood sugar. And that being the very same term for the sort of plantation infrastructures that spotted the landscape that also kind of surrounded these communities. And I guess the terms sugar machine, their use, connecting these terms just made me think of all the ways that there are these kinds of ongoing profit engines that connect the two. Soils are so depleted after sugarcane has been grown in these areas that it's hard to grow vegetables. There's all these extractive agricultural legacies kind of continuing even as they change forms. Thinking about the plantations that led to corporations, as so many scholars have noted. So with all that in mind, the kind of costly, unrepairable glucose meters seem like part and parcel of these larger infrastructures through which the death and dismemberment of non-white people had come to be normalized. Technologies built on discriminatory design, as Ruha Benjamin, so usefully puts it, don't have to be intentionally excluding, some from access to care to produce unequal survival. So for me, the sugar machine raises questions about epidemics and pandemics too. Like, how do we think about slow violences exposures if we're trying to account for these entwined histories? Or Vanessa Agar-Jones uses the term accreted violence that I find helpful. But that question of what is communicability, and I actually came to think of diabetes as not really non-communicable at all, following the long line of social observers of chronic disease, like Audre Lorde said that, 45 years ago, basically. But the poster for this class has been an interesting kind of thought exercise for me on this point, trying to think where chronic conditions like diabetes fit into a timeline of infectious pathogens where disease comes from sort of a one-time exposure. Yet at the same time, diabetes kills many more people each year than most pathogens on that timeline. It's thought to kill more than twice as many people as HIV/AIDS worldwide, for example. So those kind of astronomical levels of injuries, limb loss, blindness, organ failure, untimely death, all just made me think about the ways that biologies and infrastructures are entwined, in history, but kind of part of these ongoing profit engines too. And what are sort of the complexities of trying to visualize that? So there's been so much, sorry about that. I think the images of coronavirus that are so omnipresent in the media landscape right now, bring me to that question of, how do we think about the epidemiological imagination, to, borrow that term from Megan Vaughan, sort of not only is part of how we conceptualize disease, but also end up materializing those metaphors into concrete technologies that in turn end up shaping the biologies of people, planetary health. So it's often said, but I think always worth saying again, that infectious and chronic conditions are so entwined. Health institutions often tend to sort of over-resource or at least disproportionately resource infectious diseases. And Carlo, I think that, it's our two case studies are sort of foils maybe in some of these resource distribution problems. But for example, a lot of people living with diabetes today developed it perhaps as a side effect of the medications they were taking for HIV/AIDS. So there was sort of a whole global economy set up to be able to provide those medications seen as a moral necessity, but not for the insulin that people also needed to manage diabetes. So, and right now there are a lot of the people I know trying to manage diabetes, in Central America and elsewhere are unable to access insulin at all because of the ways COVID has transformed so many of the medical economies. Blood glucose test strips are now going for $100 a vial in Belize, which is double or triple their usual market value. So there's so much of all these bigger logics that I think are useful to think across cases with the some of the medical technologies that have now become part of COVID healthcare landscapes. So I wanted to just share one more medical object. As Dwight mentioned, I think oximetry is a really interesting case study that I hope we can talk about together in discussion. This particular medical object is also taking those measures along with a range of others. Okay. So These yellow robotic dogs were unleashed in the ER a few days after MIT Medical sent me there during my own fevers this spring. The animals carry around these cameras showing caregivers' faces from room to room on their mechanical bodies. And they're made by Boston Dynamics. And they were sort of first designed to defuse bombs in war, and now are kind of being expanded, across different domains. So I thought of this first, from a kind of patient perspective, how it only added to the dystopic sci-fi feeling of that moment, to know these are sort of like lucent hospitals. But even, the kind of logic of wanting to spare PPE by having a screen. I still wondered why such a screen couldn't be mounted on a table, for example, or like a cart with wheels. There was something very different about the sensibility that it structured. But also knowing that the readings of vital signs and biological sensing that the machine is developing could easily then be become part of what will inform the machine's training to be returned to theaters of war alongside all these other spaces. So sorry, the images are a little clunky, but it does make me think of all that the states of exception, of medicine can seem to, render neutral. These are the very same robot, Dr. Spot is a new version of Spot that months before was covered in, local papers as a terrifying technology of policing. So, yeah, I think that science and medicine have become so polarized in the US that even critical scholars can find themselves saying things like science is real. But of course, as social scholars of science and medicine, our field is sort of premised on trying to get past that sort of moralization and think in more nuanced ways about, as machines are sharing data and moving across these arenas like security, policing, medicine, entertainment, like how do we try to, figure out ways of thinking that can also follow across those domains. So yeah, so maybe I'll stop there, but I think, social theories of biopolitics that are kind of our topic for today have this sort of additional twist in the US context where there's also this kind of surreal circus of capitalism that, is part of how those spaces are being reconfigured. So I'll stop there, but looking forward to our conversation together.
Thank you both. Yeah, there are things coming together which I didn't really see before, but coming from your comments becomes really clear. Both of you working in non-communicable diseases or so-called non-communicable diseases, a category you're trying to problematize, Amy. There is this moment in global public health where there's this realization that the rest of the world also has NCDs, and that our old models of mapping non-communicable diseases onto the so-called global north and communicable diseases in the south no longer work. And here comes the pandemic and disrupts all that all over again and leaves us thinking anew about these questions. So I want to come back to that, but I want to first ask you to give us a little bit more on this idea of the pulse oximeter playing into histories of racial inequality. It seems like such a small and simple device, and one of those devices we would hopefully be anticipatory towards, a device that isn't very high cost and can be deployed in a wide resource, in a low resource setting. But it comes with these consequences. So can I invite you to maybe help us think through that a little bit?
Yeah, sure. So I first ended up thinking about that object when my husband's blood oxygen levels kept dropping during the night. And I remember staring at the machine when it was right at 92, which was supposed to be the threshold. His doctor said that's when you're supposed to go to the hospital. And I was wondering, how actually is this working and how accurate is that? And what I ended up finding was the particular machine that we had at home, which had only cost $25, was actually exceeded the FDA regulations for accuracy. There's a measurement, an error measurement called an ARM. So I could expect our machine, working on our white skin to be more accurate than the much more expensive machines in hospitals, where because of the way the pulse ox was sort of originally designed, and even today, so the current FDA regulations still only require, let's see, an 85%, the study sample can be up to 85% white. It only requires that there be 2 people with darker skin. And so because of this, the error measurements for people with darker skin often do not meet FDA safety regulations, but they're not required to, as long as they sort of do for once those numbers are blended in with the larger statistical pool. So, so these are small measurements, and even a lot of doctors kind of, thought that there's no way they could matter. But also, once the article came out, there were a lot of people on Twitter saying, like, actually, my insurance reimbursement was rejected, or, I wasn't admitted to an ER because I was off by a point or two, And so I think there are times when those things do end up mattering, even if they usually don't matter, And on top of that, there's the question of what happens when these numbers are fed to these other machines in the hospital. So ventilators, for example, are, on closed loop algorithms with the pulse ox. And there are all kinds of, triage decision-making algorithms in the hospitals now, like Epic. So there are all kinds of questions about when these slight errors, are then read by, algorithms, and in some cases, ones involving machine learning. What are the machines learning from those disparities? So, but I think it's just a case in point, again, of discriminatory design, and what happens when these machines kind of built for white safety end up being normalized.
That's really fascinating, yeah, because I didn't quite realize how it fits into the ICU loop, which a small technology isn't necessarily small anymore. It has life and death consequences. And just these fractional differences between racial measurements have such large consequences. I think, Carlo, have we lost you? I think we might have lost Carlo for a minute. Let's see if we can bring him back. Let's see, I'm guessing his internet connection has been a little dicey. I'm going to turn to a question from the question and answers and see, there's a couple to do with preparedness, but there's a really great question on, Tana asks, to what extent does capitalism in the US, in health, national security, and other contexts, influence its preparedness for a response to the pandemic, for better or worse, and compared to other countries? And since you've done research now on devices across 2 contexts, you are really well suited to speak to this.
Yeah, no, that's a really interesting question, but it's so big that this will only be answering pieces of it, I think. But something that I know I have felt with chronic disease, and that I'm now beginning to feel with climate change, and wondering about some of the early therapeutics that are coming out, for COVID now, is what, when these sort of business cycles, become part, or what happens when that, that profit engine is such a powerful motor that ends up, kind of reproducing itself again and again. And so things, that are not so easy to marketize, like different kinds of prevention measures, like all the, in diabetes, there's all the questions about, like, healthy communities, access to food and clean water and clean air, when we're talking about COVID, things like masks and all the different measures people can take that aren't, kind of necessarily a solution that one buys for sale in a marketplace. And with climate change, a lot of the new imaginaries of intervention are modeled directly off chronic disease. So, insurance policies for particular ecological features, but who will be able to afford them? Different kinds of interventions that remind me so much of Joe Dumet's sort of drugs for life, but like an environmental version of, injecting particles into the stratosphere in the case of solar geoengineering, for example, but become these new markets where these things might be available to help one survive with a chronic condition, but when there's not a market for preventing that damage from happening in the first place, that often ends up being a whole area of thought and intervention and support that could have happened that doesn't get prioritized. Yeah, so in some ways that's maybe too big an answer, but I do think the US might be especially iconic in the heights of capitalism that get incentivized, but that these logics have implications for global institutional imaginaries as well.
Yeah, and seeing that list is so interesting to see US at the top of the preparedness list and the consequences of what has happened since. I hope we can get Carlo back at some point to answer that. But Robert Smith asked a really interesting question, and this is right along the lines of your expertise, Amy. In public health literature, there is, I think, recent usage of the term syndemics, which to my knowledge, again, came from medical anthropology. If the panelists may be familiar, are they able to identify the potential tropes of this contemporary usage or the limitations of the idea of syndemics and how it is being currently implemented? And this is very much in relation to your work on paracommunicability and the difference between communicable and non-communicable. So yeah, that's a great question for you.
Sure. So I was actually thinking about this in relation to the conversation that happened in this class last week about miasma. So for anyone who hasn't come across the term syndemics, this has been a very popular and influential concept in medical anthropology that's been sort of popularized to appearing in the Lancet and being taken up by doctors. But the idea that various inequalities amplify each other, epidemics often are overlaid in different ways, and also now thinking about how climate change is often part of sort of how different kinds of health conditions, in human bodies and ecological bodies, all can amplify each other. So on one hand, I think that's completely true. I think so it's been useful as a language for explaining to people who might not already have had tools for thinking about some of those overlays. Since you ask about its limits too, one thing I sometimes wonder about with how that gets used is I think the particularities of how those things happen matter so much because they're the space where we're reminded that if there are hundreds of factors that come together in shaping something like disproportionate burdens of chronic disease, there are also hundreds of spaces for intervention and mechanisms for thinking about like specifically which policy levers are necessary, what kinds of support for say community grassroots projects that are trying to address some of those things. And so I guess for me, ethnographically, what I find interesting is to try to get into those particularities. So what some have called the science of the in-between. But, I do think that trying to get outside, the idea that such diseases are non-communicable has so often been associated with sort of just attributing them to either the poor decisions of individuals who have them or some kind of innately dysfunctional biology, which are obviously both really problematic ways to think about chronic disease. And so but I guess I always think with a concept, what does it do, and so for me, kind of getting into the weeds ethnographically about all those particular interactions is part of making visible all the work people are doing to try to work against them too.
Yeah, and thinking about getting into the weeds a little bit, your ongoing research, and also, if you don't mind me bringing it up, is so fascinating. It's on your home grounds in Pennsylvania, coal country. And after the last election, you wrote that you found yourself going back to these family sites of carbon legacies. Can you tell us more about this link between contemporary politics and the pandemic from the point of view of this new research side? New and old, as we...
Yeah. So, yeah, I guess one kind of direct connection I think about is in relation to, or I like Jerry Z's phrase, the architecture of air, and I think about fossil fuels economies as such a part of those questions. But I think some of the interconnections between what kind, how science is conceived, also connect the questions of people's understanding of causality of both COVID and climate change. And so I guess one thing that I have been thinking about a lot lately, just in relation to that question, is about how often we try to counter so-called anti-scientific thinking with more data or more information, as if that's what is needed for debunking. I would echo instead the many social observers who note that there's something else going on in those spaces. And I think of Durkheim, more than 100 years ago, talked about how people were making the mistake to think that science's authority came from its findings, but that trust in science's authority was more than anything a reflection of trust within the community that created it. And he wrote that belief in science could go away if that kind of social trust stopped being shared in community. And I think that is what's happening with both, since you invited me to think across the pandemic and some of those questions of how people think about causality in relation to something like climate change. I think those divides speak, those different readings of science are symptoms of the, the absence of shared community that created them. And so maybe that's a vague answer again, but I think it's true. There's something unsatisfying about that as a diagnosis because it's so hard to actually try to think about mending, or that's something I felt more optimistic about ethnography's potentials for than I do right now. But I do think it's a true assessment of how science is being read.
Yeah, this question of expertise, I think, is going to haunt us for a while. There's Zach asked, oh, we have Carlo back too. Hello, Carlo, can you hear us? Yes?
Yeah.
Welcome back. And we have a few questions for you from the audience that I'll just get to and skip over mine. People are really taken by the graph, the statistical kind of, not statistical, the ranking graph that you showed in the beginning. What do you make of that? What do you make of how that's played out in the contemporary? What went into those graphs? What were the variables? Was politics one of the variables that went into the graph at all? Or was it all disease modeling, some sort of technological expertise outside politics that led us to where we are in pandemic preparedness?
Well, politics did definitely not go into the measurement. I mean, they didn't take into account that there could be an administration or a government whose main interest is in creating more instability rather than less, and making instability a mode of governance itself. So and I also don't think they took into account that some political systems are extremely polarized, and that makes the management of a pandemic much more difficult. So all these things were not part of the evaluation, and also not part of the evaluation was questions around access to healthcare, social inequalities, and so on. So I think that the political was outside of the field of expertise, and the social as well.
So staying with that for a second more, there's an interesting question, and I'm very curious to know what you make of it. someone asks, I'm interested in unpreparedness. And in the US, we see refusals to mass test, unwillingness to gather data, willful attempts to depict the coronavirus as fundamentally unknowable. So is unpreparedness a sort of, I don't know, a flip side to preparedness as a logic of capital here? How do the two things work together? Because, and also, could you elaborate a little bit more on this model of preparedness and what that really means?
I think that's a very interesting question, although I mean, we could probably expand the conceptual framework and also include anti-preparedness, which I think would be something different from unpreparedness or refusal to prepare or something like this. But in terms of preparedness itself, so what happened in the context of the investments in preparedness in the United States very often is that, for instance, institutions like hospitals were required to do preparedness exercises. They had to do them every few months. So they had to play out certain scenarios and then see how they would be able to respond to a catastrophic pandemic. And so at the end of these exercises, at the end of these scenarios, the experts or those who were in charge of these exercises were always drawing up lessons learned and things that we should do in the future in order to get better prepared. But what happened at most of the times was that when suggestions were made in terms of how to increase preparedness, they were linked to funding, and then funding was not available, or they involved building institutions or hiring more people or expanding spaces. And so these kinds of investments were then not made because they were not seen as fundable or rational. And so the hospitals and the institutions just kept doing these preparedness exercises, and every time they saw the same gaps in preparedness, but the gaps were never filled. They were just constantly made visible through these exercises and these plans, and they were constantly documented. But there was no response because there was no commitment in terms of actually building institutions and actually do more than just exercises and more than just come up with more guidelines and more plans and more trainings. So to come back to the point, so in that sense, unpreparedness was built into this practice of doing preparedness itself.
That's really, yeah. So the kind of intention of preparedness practice seems to be to create conditions of instability where unpreparedness could only be the mode of response. That seems to be playing out exactly almost like you predicted. To think about technologies, now we both, Carlo, you've written more recently about mathematical modeling around the disease, around the pandemic as a sort of technology, and Amy's been talking about technologies as a sort of ideological blinder, maybe. But there's an interesting question, which I think works for both of you, is could we think of the mask use debate, and we can think of other technologies too, as a proxy for other ideological debates and not about mass science at all? Would that be ethnographically productive? Are we really talking about science and technology when we're talking about science and technology? And what do you make of that in relation to particular technologies of governance, in this case with modeling, and of risk with masks and other such devices?
So you were talking about masks as like masking, and
the question is about masking. I'm wondering whether it's also possible to think about modeling as a sort of technology to produce a particular discourse about the pandemic, which again, like you say, shifts attention away from public health in particular ways.
Right. Well, see, I mean, modeling is interesting in the context of this pandemic because it played such a huge role, and that was slightly unexpected. But it was the result of a lack of investment and interest in surveillance. So because many countries decided, or just concluded that they couldn't do appropriate surveillance, or they recognized that the virus had been spreading so fast and so quick that there was no point in trying to do proper surveillance on the ground. So that created a whole kind of gap, and mathematical disease modeling kind of filled out that kind of gap that was left by the lack of just, on the ground epidemiological surveillance. So that's why modeling became so powerful, and then modeling also became so powerful because all the interventions that were suggested came out of that modeling itself. They didn't necessarily come out of plans that had been established before, because I think, as many people probably don't know, but the idea of the lockdown was not present in any of the pandemic preparedness plans. So you can go and look at all these pandemic preparedness plans in the US, in the UK, in Germany, but you won't find the term lockdown because it was just not seen as something that is making any sense. It was seen as something as extreme, and that we would only do in an extreme catastrophic event. But instead you had a whole range of other kinds of interventions that were suggested in relationship to the severity of the event. So the lockdown just then became an option in the context of disease modeling, because these disease modelers were showing that if you introduce a kind of radical extreme version of lockdown, then you could bring numbers down. But I think there's also a larger point which is important and which I would like to emphasize, which has to do with the kind of normative orientations that are built into a focus on numbers. I think that's important to keep in mind, because so much of our discussion and so much of the public imagination of the pandemic it depends on numbers and has been driven by numbers. So if you think about this pandemic without thinking about numbers, the pandemic would have a very different shape in our imagination. But a lot of the discussions were based on and focused on numbers. And with these numbers also came a very particular normative orientation, namely to bring numbers down, to flatten the curve. But that was never really explained or made explicit as a very particular kind of ethical or normative orientation, right? So, but then the whole intervention was driven by the idea of bringing numbers down, but the interventions could also have been structured around other kinds of normative orientations. For instance, they could have been structured around how to create fair and equal access to healthcare in general during a pandemic. They could have been structured around how to build a sustainable future. They could have been structured around how to have a democratic decision-making. They could have been structured around how to have a bottom-up rather than a top-down approach. They could have been structured around how to include as many communities as possible, right? So they could have been structured on a whole different range of normative orientations. That discussion never happened because we're somehow obsessed with numbers and bringing numbers down.
Yeah, that's Amy, may I invite you to think also along these lines of technologies as proxies for ideology?
Yeah, sure. Well, since the original question kind of, tied that bigger query to masks, let me think on that, because it's true that in March, for example, a lot of the early sort of narrative about mask wearing was about like the hoarders, people who had masks were more likely to be, sort of associated with like conservatism, and so I know, at least having moved through the hospital landscape at that time, nobody was wearing masks because it was sort of like a sign of respect, or, it did become like this very symbolic thing that, to save masks for like people who were working in the COVID tents. But then it created this situation where, there were like packed elevators full of, patients and doctors, and there were all these interactions in the hospitals happening with no masks, which is, I think, where my family ended up getting it. And so, but I think it is a striking example where the same behavior, wearing a mask, kind of came to symbolize the very opposite sort of political alignment. And so, but I think that's a reminder of all the symbolic registers that are happening all the time, but also the politicization of science is so powerful in this moment that it can really kind of override things that, like, I don't know why there wasn't sort of more conversation about homemade masks, for example, in the, so I think there's a lot of constraints of imagination that happen sometimes around the moralization of object use. Mm-hmm.
I'm seeing so much of the discussion, so much of the questions revolve precisely around these questions now. For example, someone asked, do you think the move to digitize, move to technology so much and virtualize so much so quickly with the pandemic will perpetuate these cycles as we forget to address these systemic issues? And maybe that's a good place to leave a conversation on technology and politics and the pandemic. May I just invite you to give us a kind of 1 minute wrap up of what you think might be important to take away from this conversation?
Well, Amy, do you want to start?
Sure. Yeah, no, I do think that there's so much about technologies that, also, I think looking historically, one of the things I appreciate about that sort of approach is remembering that we're always at a crossroads and it depends how we're using things, but technologies can kind of lock us into certain relations and make it more difficult to cultivate others. I think that is true, but that all the more reason that it matters to pay attention to which technologies we're using and how they're designed and not just kind of delivered. Yeah, I think there's just like there's a lot of dystopian potential in the ways that people and objects are always shaping each other. I think there's also that's a reminder that it's possible to do that otherwise.
Thanks, Carlo.
Yeah, it's difficult to say something in conclusion because the pandemic affects so many different issues and has had so many consequences for all kinds of different things. But I think what's important is that we pay attention to what's happening in different parts of the world. That we have a better sense of how things have taken place in different parts of the world, because very often there's also kind of globalization going on in terms of the globalization, how we think about the pandemic, the globalization of the intervention. The lockdown has become the kind of one size fit all intervention to the pandemic, and I think that's quite dangerous. There's also a globalization going on in terms of the numbers that enable comparisons between different countries. There's a whole moralization going on. Countries are being blamed for having high numbers or praised for having low numbers. So I think all of this needs attention in terms of how numbers are being used, how they're politicized, how countries are being compared with each other. When we know that the numbers are not comparable in the first place, because all countries have different ways of counting, they have different ways of defining what is a COVID-19 death, they have different testing systems, etc., etc., etc. Nevertheless, we are ranking, we are comparing, and we think that the numbers are somehow revealing something about different places and different countries and different interventions, when in fact, I doubt it very much, precisely because these things are not comparable.
Yeah, there's something about the possibility of abstraction there that is a really interesting blinder from the materiality of the practices around COVID. Thank you so much. We're out of time and there's a million questions which we can't get to, but I'd just like to end before ending, point us to the next seminar we'll have, which is not going to be next week, but November 13th, and it's on plants and plagues. And we'll have Tristan Brown from MIT, John McNeil from Georgetown, and Jean Miguel Cristiano from North Carolina State University joining us for that. So thank you very much again, Amy and Carlo, for joining us. It was a pleasure to have this conversation, and I hope you're all able to stay well. And thanks for the attendees to join us too.